Sickle cell anemia. We're going to cover the high yield management topics for this condition. And so we'll just start with a basic definition. Know that it's related to the homozygous mutation. I'm sure you already knew that, and that it can cause vaso-occlusive phenomena. And one thing to make sure you know for the shelf is that these patients have a compensated anemia with a constantly elevated reticulocytosis. You'd see reticulocyte counts greater than 10 in all these patients, and if you don't see that, that would be a suggestion that they may have a aplastic anemia, maybe due to a parvo infection. Know that hydroxyurea improves mortality and symptoms. It's one of the only interventions proven to really help these people long term. So just know that. And the exchange transfusion is a high yield intervention that is the acute treatment for a stroke in a sickle cell patient or for acute chest syndrome. And also for splenic sequestration, however, you're unlikely to encounter that as it mostly happens in children. And just know kind of what we're doing with an exchange transfusion, where instead of just packing in new red blood cells, you're removing their blood, removing the sickled hemoglobin, and replacing it with new normal red cells. And lastly, be aware that all these patients, on the shelf at least, are functionally asplenic. And the suggestion in the question would be the Howell-Jolly body, because their spleens aren't removing those little, I don't know, whatever they are, hemoglobin, dead hemoglobin, whatever. But they tell you there's Howell-Jolly bodies as a suggestion, but they may not tell you that. But any patient with sickle cell disease who comes in with a new fever, and that's the only thing they give you in the question, you should really suspect that they're septic with an overwhelming post-splenectomy sepsis, which is a very serious disease, and we'll go over the acute management of that at the end of this. So the acute chest syndrome is something that you should know how to manage and recognize. It's an umbrella term that really refers to anything from a pneumonia or a vaso-occlusive event or even a fat embolism. And the classic symptoms are fever, shortness of breath, chest pain even, and a new infiltrate that could be just a small little mark, or it could be a complete consolidation of a lung lobe. And the acute management for this is going to be pain control and fluids, but importantly, know right here, all these patients should get an exchange transfusion. And know the antibiotic coverage, which is ceftriaxone and azithromycin. The key here is that the ceftriaxone is covering for the encapsulated organisms, and your azithromycin is covering atypical causes of pneumonia, which in these patients is actually about 20% of these pneumonias are caused by chlamydia pneumoniae and mycoplasma. And one thing to bear in mind is if you have somebody who comes in with an acute chest syndrome and sickle cell disease, and they look like they're dying in the question with a low blood pressure and signs of shock, and you see petechiae mentioned on the exam, and then they tell you that an eye exam or a fundoscopic exam shows micelles or fat globules, this is someone who likely has a fat embolism, and that's due to a bone marrow infarction in these patients. Somehow the bone marrow infarction allows fat globules to escape out into the bloodstream and lodge into the lungs. So you're going to encounter fat emboli somewhere on this exam, and in a sickle cell patient who comes in with chest pain or new onset shortness of breath with hypotension, be suspicious that they may have a fat embolism as the cause. So I don't want to spend much time on this, but just be aware that pulmonary hypertension related to multiple bouts of the acute chest syndrome is a source of major morbidity and mortality for these patients, just because of chronic lung disease, constriction, and ultimately right heart failure and hypoxia. Lung fibrosis is additionally a serious cause of mortality in these patients, or morbidity for that matter. So some of the major complications in their management. So anybody and everybody with sickle cell anemia who has a new ischemic stroke needs an exchange transfusion immediately. That's key, because the question is going to expect you to know that, and they're going to want you to know that that should happen before they go and get a head CT. So we don't even have to confirm that they're actually having a stroke. We just have to have enough evidence to say this is probably an ischemic event, maybe some new onset numbness or weakness in the arm or leg, and do the exchange transfusion. That's the first step in management. Then if somebody comes in, osteomyelitis is challenging because it can really overlap a lot with an acute pain crisis of the proximal hip. And I don't expect that you'll be asked to discriminate between those two conditions, because people in the real world, clinicians, have enough trouble figuring that out themselves. But if they did, high fever that's not getting better with the management for an acute pain crisis would be suggestive of an osteomyelitis of the hip. And sources differ on which organism is more commonly a cause of osteomyelitis in these patients. If they did ask you what the most common cause is, I'd say salmonella. But one thing to be aware of is that they may say, what's the most common hospital-acquired osteomyelitis in these patients? And if they asked you that, the answer would most certainly be Staph aureus. But the empiric antibiotic treatment for somebody with osteomyelitis and sickle cell anemia is vancomycin for the staph and ceftriaxone for the salmonella. Make sure you know those two antibiotics. Then osteonecrosis of the hip is another complication. You should suspect this in somebody who's got pain that is mostly at night and somebody who comes into the clinic complaining of a new limp or pain with walking. And I expect the question would ask you to know how to diagnose that, which is using an MRI showing a hypodense lesion in the hip. And then lastly, know the management for an acute pain crisis and know that they do not get exchange transfusions. Okay? They get pain control, NSAIDs, and hydration, and that is it. So briefly, some of the blood complications of this disorder. Just be able to recognize an aplastic anemia in a sickle cell patient. And again, like I mentioned at the beginning, they should always have an increased reticulocyte count. And anybody who doesn't have a reticulocyte count greater than 10, I'd suspect has some cause for bone marrow failure, like a parvo infection or maybe an EPO deficiency. And the key there would be if the question is giving you signs of an infection like body aches or exposure to a child with a fever, then I'd lean more towards a parvovirus infection. If they're telling you that the patient has an increased creatinine, then I would veer towards thinking that this is an EPO deficiency. Then just folate deficiency is a common chronic problem for sickle cell patients. And I would not be surprised if a question asked you to recognize that you should add folate supplementation to the regimen for these patients. So just recognize that they're at risk for folate deficiency and be aware that you should add it to their treatment. Last thing we'll talk about is the post-splenectomy sepsis syndrome. This is extremely important. It will be on your shelf, if not for sickle cell, then for another disorder. But the key here is anybody who's had a splenectomy or who has sickle cell anemia that comes in with a fever or even signs of meningitis, you should assume automatically that it's sepsis and that it's going to be rapidly progressive with an acute decompensation. These people will decompensate before you can even take time to diagnose them. So the key here is going to be starting management immediately with empiric antibiotics. And in this case, that would be vancomycin and ceftriaxone. So know that those two antibiotics are what you start immediately for these patients, anybody with fever and lacking a spleen. And additionally, you should be expected to know just basic supportive care. If they're hypotensive, you should add fluids. If they're hypoxic, they may want you to recognize that they need to be intubated and mechanically ventilated. And don't be thrown off here because post-splenectomy sepsis can also explain the development of DIC and meningitis. And I think a good way they can trick you is by trying to get you to say that we should draw cultures or do a lumbar tap prior to really starting treatment for these people. And you really should knock in those antibiotics right here before you do anything else to diagnose them, even if it means losing the opportunity to diagnose the right bacteria.